I have to say thank you also for letting me go to the Harvard Macy course in postgraduate medical education. It was a phenomenal course for the weekend, and we were able to network with a lot of very wonderful teachers and learned about wonderful studies that are being done across the country, and I think I learned a lot from it too. So what I'm going to present today is the pilot study that I took to the program when I went there last December, and then what's come of it. We're just about ready to submit this for publication, so any feedback that you have as I go through this will be very, very helpful. So the title of our study is A Simple Test of Knowledge Increases Hepatitis C Birth Cohort Screening in an Urban Hospital-Based Primary Care Practice. This is a randomized controlled trial. We're told to include this slide. I don't have any disclosures. The objectives of the talk are to, one, review some educational strategies that link residency education with evidence-based clinical outcomes, and secondly, to discuss our specific educational intervention to improve Hep C screening in a house staff-based program. So I'll walk you through our overall study background, the specific methods for educational intervention, and go through the results of our study, and then lastly, we'll open it up for discussion. The background, I'm going to cover two main concepts just so that everyone understands why we decided to do this study. The first is linking residency education itself to practical clinical outcomes, which I think you all have a lot of background in. And the secondly is just the rationale behind why we chose to study the hepatitis C birth cohort screening as our main project. So as you're all aware, our healthcare system is sort of transitioning to a pay-for-performance model. And in such a model, we are expected to train trainees to understand their clinical outcomes, as when they go into practice, their clinical outcomes will be tied to financial compensation. So in an effort to sort of equip trainees with these skills, the ACGME back in 2001 with the Outcomes Project incorporated these two core competencies that you're all very familiar with: practice-based learning and systems-based practice. And these two competencies are really meant to ask residents or ask trainees to critically reflect on their practices and then think about how they would incorporate skills to improve their outcomes. There's probably been some sort of a gap in actually transitioning these core competencies into practice, into both an education standpoint and in a practical standpoint, until probably 2009, 2010, and there's been a lot more in the literature. I think that was ever since the adoption of a milestones-based accreditation system. And I think with these milestones and the accreditation system sort of shifting, there's been a little bit more of a ramp up in terms of how to best educate residents on these two core competencies. So I think we all still have the question when we're trying to train trainees, and as a trainee myself, is how do I best improve my clinical outcomes, and how do I best teach trainees to do that? And I sort of thought back and went back through the literature and looked at how we look at education, how do we look at medical education. And there's all these different methodologies behind education, and there's pros and cons to each one of these. So is it through a large lecture hall that's the best to educate? Is it through in small group trainings? Is it purely by attending supervision on rounds? Is it by case-based learning, practical experience, or is it by getting reports, these QI reports that we get, and just expecting residents to sort of self-reflect and improve their practices? And I don't really think that we have the answer for what the best modality is or what the best combination of modality is. And that's sort of where our question came from when these guideline changes were made. So what we do know about adult education theory is partially based on Malcolm Knowles' principles that I think in order to best educate adults, that the education should be problem-centered and it should be relevant to the workplace. And that this sort of provided us with a framework to think about our project, and it made it a little bit relevant as well for education. So in order for us to have a problem-centered approach, we thought hepatitis C screening in baby boomers, very specific, very problem-centered. And then secondly, relevant to the workplace. This is a new primary care guideline, a new recommendation that we thought would be very relevant for the trainees to get educated about. So this is where we started in terms of thinking about how to best educate our trainees about this new guideline change. But before I get to the guideline change, I just want to provide a little bit of background on hepatitis C screening to give you some rationale and just to provide the principles behind why the guidelines did change and why we thought that it was important for our practices to change sort of in accordance with these guidelines. So some of you, or most of you probably do know this, but after an acute infection with hepatitis C, there's a very small percentage of patients, maybe 20 to 30%, that are actually symptomatic. So most people do not realize and are not symptomatic from an acute infection. 15 to 25% will clear their infection spontaneously, meaning they won't need treatment. They may never know that they even had the infection if they cleared it spontaneously. And the remainder, 75 to 85%, go on to develop a chronic infection. And this can result over time, over a course of 20 years, there's a 10 to 20% risk of this sort of progressing and causing cirrhosis or significant fibrosis and scarring of the liver. And unfortunately, during this period, on the spectrum of disease, most patients are not symptomatic. So there's nothing that would bring them into care saying, I should get tested, I should get treated, unless very clearly risk factors are delineated by the primary care doctors. So it really isn't until patients start to progress after cirrhosis and develop decompensated liver disease, which happens in a significant proportion of patients, or develop HCC, where if you have cirrhosis, there's a risk of about 1 to 4% per year, that they present then to primary care or present to our liver practices with symptomatic disease. And at this point, our treatment options are limited. Transplant, or if the HCC is very widespread, maybe a chemotherapy or maybe local regional therapy, very limited treatment options. So our goal, especially in an era where we do have all oral regimens to treat hepatitis C, is to capture patients that are sort of along this spectrum. Well, actually the goal is to prevent this altogether from happening, but then the secondary goal is to really capture the population of patients that do have the disease and are not yet symptomatic from the disease, and to treat them. So that's sort of the background of hepatitis C and the natural course of the history. There's been a lot of modeling over the past 5-7 years or so that looks at our rates of hepatitis C throughout the nation and what the burden of disease is expected to be. And this is based on Markov modeling. And you can see here that the rates of hepatitis C infection and prevalence are just expected to rise, and the deaths due to this are expected to rise over the next 20-30 years. So and really the only definitive treatment that you can see here is transplants, and the number of transplants really isn't expected to increase. So the goal is to really prevent the burden of morbidity and mortality from hep C-related disease early on. It's estimated that there's probably about 3 million patients that are in primary care practice that are chronically infected with hepatitis C, and about 900,000 over the spectrum of their lifetime are expected to die from hep C-related complications. So a significant burden of disease that's in primary care practice. And I think what complicates that burden and sort of fits along with the natural history of hep C is that a significant proportion of patients with hep C are not yet diagnosed. And this is a pretty dramatic graph, but I think lays out the picture very well, that compared to HIV, where 20% of patients are not diagnosed, that approximately, this is probably more closer to 50 to 75% as opposed to a hard 75, but a significant percentage of patients are not yet diagnosed. So the goal is to really capture them in this, and to capture these patients and to get them linked into care somehow. There's been data through the NHANES, the surveys through NHANES that look at the prevalence of hep C within specific birth cohorts, and trying to figure out what the best group is to really capture and start screening, or to start getting linked into care a little bit more closely. And when you look at both the NHANES survey groups, the one from 1988 to 1994, and then the second one from 1999 to 2002, you can see that persons that are born after 1940, so 1945 to 1965, have a significantly higher prevalence of hep C infection compared to other birth cohorts. So although this birth cohort, referred to as baby boomers, makes up about 20-25% of the US population, it accounts for about 75% of all hep C in the country. So with that in mind, both the CDC and the United States Preventative Task Force Services, the CDC revised their screening guidelines to say that we do recommend a one-time hepatitis C screening test for all persons born between 1945 and 1965. And then secondly, the United States Preventative Services Task Force followed suit and recommended that we do the same. So that sort of, I hope, lays out the background for why we thought this was an important project to sort of pursue, that we realized that this was a problem, and that with these guideline changes, how do we then change the primary care practice, and how do we best educate our trainees to change their practices? So the aims of our study were to educate medicine residents on these guideline changes related to hepatitis C screening. And the second was, and I'll go through this in a lot more detail, was to study the clinical impact of these 3 distinct educational modules on hep C screening rates within a primary care clinic. So to go through the methods in more detail, I think we specifically chose the internal medicine residency. It's the residency that I went through, not here, but it has a very large cohort of primary care patients. So we chose the IMA practice, which has 132 internal medicine residents. There's a relatively equal distribution of postgraduate years 1 to 3 within the IMA practice. And the residents in general have somewhere between 76 to 88 half days of clinic sessions a year. So what we started with, we went back. This is looking at 2014 to 2015's academic year. What we started with was an electronic survey to just assess baseline knowledge of hepatitis C. And this was a survey that was distributed in September 2014, very quick, 10 questions that were multiple choice, true, false, and we really just focused on the knowledge and the application part of the Miller's Pyramid to get a sense of what routine understanding was of hepatitis C and who should be screened. We kept the survey open for a month, sent a lot of reminders during that month to get the house staff to respond. And we did this electronically. This just gives a sample of some of the questions. Some of them were demographic, and the others were quick answers for what test would you order, who would you test, and we graded this subsequently. The next thing that we did, and this is something that we're still actually doing, is in order to sort of have the clinical aspect of this, was looking at our hep C screening rates on a monthly basis. So these are reports that we were able to get generated by our IT department that we obtained every month, and had a list of all of our primary care baby boomer encounters within the IMA practice, and it included demographic information along with the results of a hepatitis C antibody test and the date of that result. So we were able to find out if patients had been screened in the past, if they were newly screened, and what the results of the screening test were. If there was a positive test or a positive screen, and we wanted to see what the follow-up, confirmatory viral load, hepatitis C viral load testing was, or if they were referred to care, that was all done by primary chart review separately. So in order to obtain baseline screening rates, we went back to the prior academic year, the 2013-2014 academic year, just to get a sense of what screening rates were already. And the 2014-2015 academic year was the study period where we pursued these educational modules. So the educational modules were, I have to say that our initial idea was actually to have more of a randomized trial between in-person teaching and having different models of in-person teaching, and it became very difficult to do this logistically, and I think this is probably something that we see often, but getting to all the residents in a specific period of time and making sure they get educated in the same manner was impossible to do. So we ended up then transitioning to more of a self-study electronic module system. So this is then the modules that we set up, and there were 3 modules that we created. And this was with the help of our liver experts that are in the room right now too. But there's 3 specific electronic modules that we created. The first was a pure step-by-step process on how to order hepatitis C screening in our system, and it linked in some of the electronic alerts that were going on and how they just had to address them. The second was a series of didactic slides on hepatitis C screening. Very similar to the background slides, where the natural history was there, some text about why the guidelines have been changed and that it needs to be incorporated into primary care practice, and then along with these step-by-step instructions for how to screen patients. And the last was a more case-based module on who needs to be screened, what you do with a positive test, if you have cirrhosis, what do you do? And it was a lot more interactive. You click buttons, answer questions, and whatnot. So as you can see, with each of these modules going down, there was just an increased degree of problem-centered instructions and a greater clinical content. These modules were all created on PowerPoint and transitioned into an Adobe format that was then posted on Blackboard, a commercial content management system. So the residents, there was 131 that ended up being included, but the residents were divided into 4 groups. One group served as the control and did not receive an electronic module. And the first group received just the process module, the first one I described. The second group received both the didactic module, received just the didactic module, the second one I described, and the last group received the case-based interactive one. And there's a bar that's going across here just to make it clear that during this time period, there were hospital-wide or system-wide interventions that were also being implemented, and the residents or the trainees were equally exposed to these interventions. And these included just the electronic alerts that we had implemented, some flyers that were being posted around, and they should have been exposed relatively equally. The outcomes that we looked at, so the first outcome was just the survey results, which I'll show you, and the second was to look at the effect on our hepatitis C screening rate. So this was calculated, the overall screening rate is what we looked at, which just meant that there was a one-time Hep C antibody test done within our system at some point during the patient's record up here, and that's the overall percentage of screening that we looked at. And then we compared the screening rates between those four groups that I described on the slide before, and then we looked to see whether or not there were changes in screening between these intervention periods. So we divided up the intervention periods into 3 specific time points. There was a pre-survey period, and the survey was sent out in September. There was a 2-month post-survey period before we sent out the electronic modules. The modules were sent out for a total of 4 months, and then there was this post-educational module period. We started measuring the post-educational module period here only because anyone that completed them really ended up doing it early on. And in terms of our analysis, the survey results we manually sort of graded in a blinded fashion. They were all anonymous results. And then we compared the screening rates over time just with chi-squared analysis. And I think it's easiest to think of this as we ended up performing both an intention to treat and a per protocol analysis. The intention to treat, we really just kept the residents in the groups that they were analyzed in and looked at their screening rates over time. And then the second thing that we decided to do was, and this will make sense when I go through the results, is a per protocol analysis where we looked at the residents that completed the modules and grouped them together, and then the ones that didn't complete the modules just to see their screening rates over time. Any questions? Yeah.
How did you choose the 3 different modalities? Like, was there based on a literature review?
There was, in terms of modules for Hep C screening, there really wasn't any literature about this. I think it was sort of how, our goal was to improve our screening rates, and I think that there was 2 ways of doing it. One was just tell them how to do it, and the second was explain to them how to do it, and then hopefully they'll do it. So in the explanation part, that's when we thought maybe a didactic component or a case-based component. And there's evidence in the literature about using these modalities, but in sort of an electronic format, I could not find much, honestly, at all. So it was sort of what we thought would work, wouldn't work, and there wasn't much of a basis for it in the literature already. Okay, so I will go over the results next. We'll go over the survey results, and then secondly, how the screening results have changed over time. So 131 medicine residents were included overall. 1 resident was excluded because he's helped me significantly with this portion of the project, so it was not included in the results. This is the breakdown in the PGY years in each of the groups. So the reason why the control group is a little bit bigger is that the residents were grouped into these groups based on their practice teams. So there was 4 practice teams included in the control group, and then each of the other groups had 3 practice teams. And it was very hard to divide up the practice teams because of the way we were feeding back the data too. So we ended up having a slightly larger control group, and then the other 3 groups were relatively equal sized. In terms of the patient population, there were on average about 1,345 baby boomer encounters each month within the IMA practice, which is a lot. It's a lot. The mean age of encounters was 59 years, 65% were female, and 48% were of a Hispanic ethnicity or identify as Hispanic ethnicity. The baseline HCV screening rates, this is going back to the academic year 2013 to 2014, were 54%, so about half of patients had an antibody test within our system, and 2.5% were antibody positive, which is actually lower than what we would expect based on prior published results. So the survey results, 61 residents completed the survey, and this was after, I'd say about 6 emails that went through over a course of 4 weeks, so that's about a 47% survey completion rate. not the best, but you'll see what the educational modules were in a second. And in terms of who completed the survey, it was a relatively equal distribution between PGY1 and PGY3 years. And from the survey results, I think two things stood out to us. One was that 100% of residents knew that they should be screening people that were born between 1945 and 1965, and 98% correctly identified our antibody test as a screening test of choice. So when you look at, we next grouped all the residents based on their assignments and just trended their screening rates over time. And this is what we found. These were overall, regardless of whether or not they completed the educational modules, keeping them within the group that they were assigned, these are what the screening rates tracked to. Only 28 residents completed our educational modules, and this was sent out over a course of 4 months. The highest completion rate happened in the first month, where about, I think, 18 or so did it. In the second month, there was a few more that did. The third month, there was 2 more. In the fourth month, there wasn't any. So a 21% completion rate for the educational modules. And if you look at the screening rates over time between each of these groups, you can tell that they mirror each other and are very parallel. But what I thought was interesting, and the most interesting, was that there was a very significant increase starting after September. And the one thing that we did in September was the survey. And I think that was the one question that we then had in mind. So before we talk about the survey results again, this is sort of the per protocol analysis. If you then look at the folks that completed, the trainees that completed the modules, and compare them to the trainees that didn't complete the modules, this is just the characteristics of both of these groups. So relatively equal distribution of PGY1, 2, and 3s in both the completers and the non-completers group. And if you look at the one thing that stuck out was that there was a higher percentage of patients in the Group C, and remember Group C was the case-based interactive module, so there was a higher percentage of trainees in Group C that were completers as opposed to non-completers. And I think what is interesting is that if you look at the pre-survey Hep C screening rates, there's a big difference between the completers group and the non-completers group. So the trainees that were at a higher screening rate to begin with, starting in July, that had a higher screening rate to begin with, were more likely to be completing the modules. So I think that just some food for thought. And then if you look at what happened to the folks that were non-completers, the people that didn't even touch the modules at all, following the survey, those 2 months following the survey, their screening rates increased significantly. So, and they pretty much matched then what the trainees that completed the educational modules were. So there was an increase in screening rates after September. The greatest increase ended up being in the folks that didn't end up completing the modules, but what happened in September was the survey. And just for a visual depiction of what we just said, if you just group the trainees that were the module completers is in the blue, and the control group or the non-completers are in the pink. And I should say that the trainees that were assigned to the control group, I included as non-completers because they never received anything. If you just look at their screening rate, just a visual depiction, that in September, it really was this group that sort of drove up that entire rise, and then it sort of has been parallel the entire time. So this brings us back to why we did this to begin with, and just to open this up for some discussion. So our initial goal when we laid out this study was to really figure out if a type of educational strategy would affect clinical outcomes and affect screening rates in practice. And I don't know if we can specifically say that based on our study for a few reasons, but I think that we did find a few things. The first was that our survey results indicated that our knowledge was actually okay in the trainees. That they knew that there was probably a practice change or a guideline change, and that they should be screening for hepatitis C. But that there was clearly a gap between their practice and their knowledge, because their screening rates were still about 50%. So what causes this practice gap? And we talked to, I had a resident who was working with me on this project, and we had several focus groups with the residents too. And I think that what is in the literature is sort of what bore out here too, that time pressures, competing demands, and I think that this specific IMA population that has substantial healthcare needs also really affects what you are able to do in a 15-minute clinic session. So that is a lot of what leads to this practice gap. But I think that sort of still, it's not despite those things which exist, I think, in every practice, it's not a reason to accept a practice gap. And I think we have to figure out still what the best way is to mold trainee practices to change when guidelines do change. So what we believe is that the test that we sent out at the beginning, our survey, is what ended up causing the most significant rise in screening rates. And it was in a group that probably did not really incorporate much of the guideline changes at the beginning. So whether or not this can be done in other screening practices, we can sort of talk about, but the modules themselves, we can't say ended up having any impact on the screening rates, mainly because I think the completion rate was so small. Why the survey results led to an increase in screening rates, I think there's a few theories. The first is that if you aren't screening, you get a survey and you realize that, oh yeah, I'm supposed to be doing this. I think it does lead to some potential cognitive dissonance within someone and gives yourself some self-reflection or allows you to self-reflect and create this environment for change. And I think that's probably what happened in the group of residents that weren't already screening, is just by receiving something saying, hey, there's a group of doctors here that think this is important and that we should be doing this, that they then end up changing their practices. And allowing for that self-reflection. The limitations of our study, like I said earlier, the module completion rate was low. So I think studying the effect of that, which was our initial aim, we actually could not do, and we weren't able to answer that question. I think the second is that in addition to these modules, there was a lot of system-wide changes that were happening to improve our screening rate. So the isolated effect of the modules or the isolated effect of the survey are actually really hard to decipher. What we can tell you is that there really wasn't anything else that specifically changed in September that would have caused the increase in rates. We had started these data feedback reports, and that started a few months after that. The electronic changes that were made a few months before that, so there wasn't really anything else in September that coincides so exactly as when that survey was. And the last is that there is, whether or not this can be generalized to other primary care practice settings, we're not entirely sure. When we go back to our residents in the IMA practice, there's only about 11% that go into primary care. So perhaps the burden to change behavior is a little bit higher in our group as opposed to other groups where there's more folks that are going into primary care practice, but I'm not so sure. There are a few strengths of our study that I think are worth mentioning. The first is that we specifically looked at a clinical outcome measure, and I think that's something where a lot of QI projects, and even the ones that I've done in the past, specifically look at process measures. Are you checking LDLs in your diabetic patients? Are you doing the your neuropathy exams, your microfilament exams in your diabetic patients? But looking at a specific clinical outcome measure directly linked to an educational practice is, I think, is a strength to our study. And I think that the second thing, and leading back to what the basis of this study was with Malcolm Knowles' principles, is that we very clearly linked a clinical experience to the learning process. And not everyone completed the learning process through the modules, but about 50% did through the survey. That I do think that connecting the two potentially did make a difference early on when we saw the change in our screening rates. So what we can conclude from this, and I think is open for discussion, is that for specific guideline changes, and this obviously can't be for everything, but for specific guideline changes, that a simple test of knowledge, a survey, a simple test of knowledge may be adequate to result in practice change for a group of trainees. And if you think about other similar guideline changes where this could apply, and I was just brainstorming about this, and there's a chance that in the next 3 to 5 years that colon cancer screening guidelines might change to incorporate our Cologuard test. So is it going to be feasible to sit down in didactic sessions or small group sessions and teach all of our residents about these guideline changes? Probably not, and I think that we'll have to figure out a more feasible modality of doing so, and maybe something similar, not the educational modules, maybe something similar with a question-based learning environment where you do open residents up for self-reflection is the way to do it. So this is, I want to thank my entire team for obviously helping me through this. I was just one part of this. Bridgen is not here today, he's at IHI, but he helped sort of formulate the educational modules and taking it through the residents and taking it to the residents. Dr. Pani Perumal-Swamy has helped incredibly. She's a main PI for the entire system-wide screening project. Colin is the resident that helped me a lot. He's a second-year resident here. And then Dr. Dietrich, who's our main PI as well. So thank you. Those are the results.